Hi, and welcome to Living Connected. I always joke around that everybody's got a podcast, and why does there need to be a new podcast? And so here I am starting a new podcast, and you're probably wondering why. Here's how Living Connected started. Is as I go through the healthcare industry and meet new people, I've just had some really, really cool conversations with some very interesting people that have some really neat perspectives and frankly just have really neat jobs. And I wanted to record them. And my hope is that as an audience, you guys follow along in my journey as I meet some interesting people and have some conversations, and hopefully they inspire you or educate you or provide a unique perspective that maybe you haven't heard before. So, with that, I wanted to kick off our first podcast guest, Dr. Rob Lash from the Endocrine Society. He's the Chief Medical Officer of the Endocrine Society. And here's the funny thing. So, one of the things I always tell my kids is there are no coincidences. I truly believe you are just meant to meet people in your life, and it's up to you to take advantage of it and seize the opportunities. So last year when I was undergoing cancer treatment, one of the ways that I found, frankly, peace and joy and fun was to go to concerts. And a lot of my kids didn't want to go with me, and sometimes my husband didn't want to go with me. So this was one of those nights where I decided to go to a concert by myself and decided to grab dinner by myself before the concert. So I'm sitting at the community table in this restaurant in Cincinnati, Ohio, and there were a couple people that sat, before Rob did. Guy to the left of me, I didn't really want to talk to him. Before that, there was a gal in front of me. I didn't want to talk to her. There was something about Rob. He sat down and I looked at him and I thought, I don't know. I feel like saying hi. So I said hi. He said hi back. We started talking and then we started going into, okay, what do you do? And he said, oh, I'm with the Endocrine Society. And I said, no kidding. What do you do there? And he said, well, I'm the Chief Medical Officer of the Endocrine Society. I said, no kidding. I'm the Chief Medical Officer at CCS and we specialize in diabetes. So clearly the universe meant for us to meet. And Rob, I am honored and delighted to have you as my first guest on this podcast. Can't wait to go into some of the work that you're doing with diabetes and Endocrine Society in general. And frankly, just really feel fortunate to be able to call you a friend now. So thank you for coming on the podcast. I really appreciate it.
Well, the feeling is very mutual, Arti, and I thank you for inviting me to join you today.
No, this is going to be great. And I should tell you also, Rob, that the reason I called it Living Connected is one of the things, and I don't know, maybe some people feel like I'm a little Pollyanna about all of this, but going through COVID and then certainly going through the medical treatment journey that I went to, one of the biggest epiphanies that I had was that the greatest wealth that we create in our lives is connection and love and surrounding ourselves with people who care about us and that we care about. And especially in healthcare, if there's no connection and there isn't that joy and love for each other and taking care of each other, then what is really left in healthcare but a transaction, right? So that's why I called it Living Connected. I don't know. Is that crazy?
No, not at all. I think it's a great way to think about healthcare and helping others.
So what does Living Connected mean to you? Because I'm sure as you read that, there's probably a personal thing when I say that. Does it mean something differently to you? I'm just curious.
Oh, that's a great question and a little bit thought provoking. I think it's certainly given what you do and the connected part about people. If you have diabetes and you are connected in many ways to the technologies that you might be using, whether it's a continuous glucose monitor or a pump or a digital health piece of software. Where you're interacting with someone at the other end of your phone. I mean, that certainly is a perfect example of being connected. I think for people who are involved in healthcare, it's that connection to their patients, but also to the people with whom they work. Their fellow healthcare providers. physicians, nurses, medical assistants, certified diabetes educators. And that piece of connection is good as well. And I think it also applies to the work that we do, the people we work with in our organizations and the people our organizations serve. So that connection, I resonate with that. It means
Yeah.
a lot to me as well.
Yeah. So one of the next guests on the podcast is going to be Dr. Buddy Hammerman, who's a friend of mine from many years ago. He's a chief medical officer of an LTAC
Mm-hmm.
organization company, and he and I are going to talk about connections that foster joy and wellness in physicians. So I'm glad you called that out, actually.
Mm-hmm.
So all right, let's talk about some of the work that you're doing with the Endocrine Society. And I'd love to start, I think the audience would be interested in knowing how a physician of your caliber, just talk about your journey, because you were at University of Michigan. You were there for years. And I mean, the Jedi Master of endocrinology and publishing and educating and all that stuff. And all of a sudden you're at the Endocrine Society. How does that happen?
Oh, well, I appreciate the setup there. But I was indeed lucky enough to be at the University of Michigan for most of my career. I have been there about 20 or 21 years and had and enjoyed almost every aspect of my time, not only at the University of Michigan, but also in Ann Arbor. But as our youngest child was finishing high school and about to start college, my wife and I began to talk about, what else might be out there for us to try, what new adventures might be out there for us to take. And by coincidence, the Endocrine Society was looking for its first physician staff member. Now, interestingly, from at least my perspective, the Endocrine Society is the world's largest organization of endocrinologists and people who take care of patients with hormonal disorders and people who do research on hormonal disorders. And it's over 100 years old. It has over 18,000 members. We're in 120 plus countries, but we never had a physician on staff. So around that time, the person who was leading the society thought it would be a good idea to finally bring a physician on staff and asked if I would like to take that on. And it was really the right opportunity at the right time to make a move and to join an organization and to try to make a difference in the lives of people all over the world who take care of patients with hormonal disorders and who do research on endocrine disorders. So let's just say it was an offer I couldn't refuse.
Yeah.
And I was delighted to take on this challenge.
Yeah. So speaking of challenges, I'm sure you have a lot on your plate, right? If you made a list of things that you want to solve for, what are the top few or one or two? I mean, are there things that you're like, this is something we need to address ASAP because it's going to be a problem?
Yeah, so I'll start with the one that is the top of my list. And the top of my list is that the number of medical students in the United States who want to become endocrinologists has been falling, and we need to be doing more to attract medical students and people who are training to be internists or pediatricians to think about endocrinology as a career. So that's really very close to the top of my list right now. Related to that is what we can do to help improve the quality of life for people who are working in the endocrine field. Burnout is a real issue for people who practice across the healthcare spectrum, whether you're a physician or an APP or someone who, like I know we're talking diabetes today, certified diabetes educator. Mm-hmm. So that's another big issue that I think we need to address. And I think a third issue is making sure that our nation's commitment to funding research in diabetes and diabetes-related diseases continues to grow. And that means not only clinical research, but also basic science research, and also caring for people who have diabetes who may not have the resources to avail themselves of all the medications and technologies that are available today.
So can we start with the first one with what is it? Is it correct to say that we have a shortage of endocrinologists in the country, Rob?
It is absolutely correct to say we
Okay.
have a shortage of endocrinologists in the country.
What should it be? And what are the numbers? So
Oh
yeah, I
gosh, the
yeah.
numbers are hard to. It's hard to pick. It would be hard for me to say if the magically 1,000 more endocrinologists appeared or 5,000 more endocrinologists appeared, all our problems would be solved. There are about 7,000 endocrinologists in the U.S. today. That number is probably going down slowly. It's always hard to get a tab on that because people are retiring.
Yeah.
COVID uh,
Yeah.
had a lot of
Well,
people
people are
reconsider.
retiring and not new folks are coming in, is what I'm
Right,
hearing.
right.
Okay.
So what some people are saying is that, well, if we just expand the number of training slots and just make more endocrinologists, our problem will be solved. And there are two issues there. The first is you can create more slots, but we don't have the people to fill those slots. And the second problem is, where do these endocrinologists go when they're done practicing? It's very easy to say, oh, we'll make more endocrinologists and we'll open some new programs in Boston and New York and Chicago
Right.
and San Francisco and Denver. And then we'll have a lot more endocrinologists in Boston and New York and San
Right.
Francisco and Chicago and
Yeah.
Denver. But we're not going to have them where we often need them,
Right.
in the Southwest, in the
Yeah.
Pacific Northwest, in the more rural counties in all of our states. Um, I think it's important for us to realize that there's more to the problem than just making more endocrinologists. It's making good ones and making sure that they have an opportunity to care for people wherever they are.
Yeah. I was one of the first things that I learned, well, one of the many things, one of the many first things that I learned when I started in this role at CCS was that especially when it comes to diabetes. I mean, certainly for other hormonal disorders, right? There's a clear path for endocrinology, but I think many people would say, well, internal medicine physicians like myself or a family practice physician, they should be able to manage diabetes. What I didn't fully appreciate is how complex diabetes can be, not just type 1, but type 2 and some of the new treatments coming out. And I was surprised to see that there are differential outcomes when a patient sees an endocrinologist versus a primary care physician in terms of A1C reduction, not just the value, but how fast you get that reduction. And there is something to be said, right, for specialty training in managing diabetes, both type 1 and type 2, as opposed to, I think, being a generalist, which is how I was trained in diabetes.
Right. I think that's an excellent point. There are a lot of people with diabetes in the U.S., and endocrinologists could never take care of all of them. And I think one of the pieces that we need to figure out is who needs to see an endocrinologist and who does not need to see an endocrinologist. And not only that, how can people from different areas of medicines, specifically in this case, endocrinology and family medicine and internal medicine, work together to make it possible for people in primary care to provide great diabetes care for the vast majority of people with diabetes who don't need to see an endocrinologist, and then to make really smart decisions about who needs to move from seeing a primary care physician to seeing a subspecialist. And that conundrum exists across all medical subspecialties. And I have nothing but respect for people in primary care who have to walk that tightrope for pretty much every disease they treat. Who can they take care of and who needs to see somebody in the specialty world? And it's a big challenge for people in primary care as well, because the more people they refer, the longer the wait lists get.
Yeah.
And so I think you've hit on an incredibly important problem, which is, who needs to see an endocrinologist and who does not, and how do we make sure that the communication between subspecialists and primary care providers is there and working well. And I think now we also have to add in the extra dimension of what you're doing at CCS, which is providing chronic care management as another important player in this relationship between primary care, so specialty care, and DME care.
Yeah, I think from a CCS perspective, the whole goal of the program really was to offload some of this burden from the physicians, specifically primary care physicians. I don't know. I mean, Rob, it just seems like there's so many new technologies coming out, and I'm excited. So at the end of the next week, actually, I'm going to my board prep for this is be my second time taking the board, so I'm getting a little older.
Good luck.
Yeah, thank you. It's been a while, but I'm excited to learn all this stuff. Like, just so much has happened in the past decade, and I can't imagine that PCPs, especially these days, have enough time to get their CMEs and keep up with the latest and greatest. I mean, how do you think about the technology, both from a device and medication standpoint, in diabetes in the past decade? Like, what's gotten easier, and then for the patients, but then on the flip side of that, how has it made things harder for prescribing physicians from a management perspective?
Yeah, look, that is a great question. I think what has made, particularly in diabetes, what has made taking care of patients easier is the number of new and highly effective medications that we now have available to us that really importantly don't cause hypoglycemia, don't cause low blood sugars. If you look back even a decade, almost, there were very few, most of the medications we gave, insulin and sulfonylureas, caused hypoglycemia, and the only drug that really didn't was metformin.
Metformin, yeah.
And
I
now
remember
we
being trained on glyburide. Everybody got glyburide,
everyone
metformin
got
and
glyburide,
glyburide.
right now,
Yeah,
and now very, very few people should be getting
right.
sulfonylurea, should be getting glyburide.
Yeah.
But since then, we've had a number of new classes of medications come out. The DPP-4s, the SGLT2s, the GLP-1s, that are all effective treatments for diabetes, none of which cause low blood sugar, all of which are pretty much relatively straightforward to use once you know the doses and you kind of know the routine of how to titrate up the doses. And I think this has made a real difference in that the number of people who need to move on to insulin gets smaller as these drugs become more available and become and have demonstrated effectiveness. So I think that's been one area. Technology has been, I think, a mixed blessing for people who take care of people with diabetes. And I say that because we now have continuous glucose monitors that are easy to put on and easy to use and talk to your phone and generate reams and reams of data, which has to go somewhere.
Right.
And part of the challenge there is if you put 25 patients on a continuous glucose monitor and you've got 25 people sending you their last 2 weeks of blood sugar every 2 weeks, you're going to be drowning in the data.
Yeah.
And you may or may not be able to make smart decisions about what they should do next. This is a bigger problem for people who don't have a diabetes education staff available to them, and that would be pretty much everyone in primary care.
Yeah.
So this kind of technology can be a mixed blessing. I would say on the fortunate side, particularly in the world of people with type 1 on insulin pumps, the technology is moving so quickly that the number of automated systems is increasing, and more people are going to be on systems that do all the heavy lifting, figure out what your blood sugar is, figure out what you just had for dinner, and help you take care of your blood sugar without you being very involved in the process. So um, technology giveth and technology taketh away, I think
Yeah.
is one of the messages
Yeah.
here.
It is. I see. I went to a digital health conference earlier this year, and you have a lot of companies that are boasting about their ability to integrate with electronic medical record, and we can actually send you this. And I'm thinking, I mean, I don't see patients full time anymore, Rob, but I still make an effort to go in once or twice a month just so I don't
Sure.
forget what it's like to be on the caring end of this. And when I pull up Epic, there's so much information. And
Hmm.
what I don't want more data actually. What I want is actionable, more interpretable data. It's almost like I don't want that. Give me the interpretation of the X-ray
Right.
so I know how to use it as opposed to some of this raw data. I think it's a really good call out. And I also think about like wearables and how many patients now go to their doctors with their, I wear a smart ring, but some people have smart watches, and you combine all this stuff. And, I think about your earlier point about physician burnout, and I can't imagine that it has to be helpful if that stuff isn't filtered down to something that's actionable and in the context of what you're doing in that patient's visit.
That it's hard to argue with any of that. I mean, that makes sense. I mean, being able to make sense of the information that you get, um, I think for people who practice medicine, when a patient comes into the office and they've got a thick stack of all their notes and lab tests and everything, and you've got 15 or 20 minutes
Right.
to do everything you need to do, that is a huge challenge. Electronic health records only add to that burden because now you have everything that's in your EHR and all the information that's in every EHR that's connected to your EHR,
Right.
it can get overwhelming at times, and there's a temptation just to copy and paste as much information as you
Yeah.
can from one note to the next, and that doesn't bring value.
Yeah.
That just ticks boxes for billing purposes, and the important thing I think here is bringing value to patient care,
Yeah.
which is one of the reasons we're talking today.
Yeah. So in that first problem about the shortage of endocrinologists, so how are you inspiring medical students and residents to choose endocrinology?
Well, well, I'm really glad you asked because we are embarking on a few programs that we think are particularly exciting. Um, One that we started around the time of the pandemic, we call the Excel program, Excellence in Clinical Endocrine Leadership. And this is a program for endocrine trainees who are from groups that are underrepresented in medicine, where we teach them leadership skills, teaching skills, help with mentorship and professional development. And the idea is to help these endocrine fellows become the best young endocrinologists they can be, and to be role models for the people that they'll be teaching and training as they start their practice. This is a program we'd like to expand beyond groups that are underrepresented in medicine because we think these are skills that everyone can take advantage of. A second program that's in its second year right now, we call it Endocrine Mentor Day, and we do this at our national meeting each year where we invite about 75 medical students and residents who are in the city that we are having our national meeting in to spend a day at the meeting with us. And we put on a great show. We give them all glucose monitors to wear during the day. They get to meet the president of our organization. We take them to the best talks. We give them a gift certificate to our store that they can get the finest Endocrine Society swag, including our always popular gland socks, and just try to get them excited about the field. But the last program I want to tell you about is the one that I'm most excited about, and we're calling it our Medical School Engagement Program. And in that program, we are awarding a small number of medical schools grants to do a few things. One is to create endocrine interest groups in their medical schools. and to identify specific faculty who will have protected time to form these groups, to have these meetings, to get medical students interested in endocrinology by presenting interesting cases, talking about new research, bringing in patients, just to put endocrinology in front of medical students, because we know that people make their career decisions early in their medical training, and we want to make endocrine an exciting opportunity. And our goal is to make more of our students become our colleagues.
Yeah.
We're also giving out 2 awards to each of these medical schools for the 2 best medical students who are at the school, one in the first 2 years and one in the second 2 years. And we will bring those winners to our national meeting each year and make sure that they have an experience that will get them even more excited about endocrinology.
Awesome.
So we're going to select 5 medical schools this year. And we were lucky enough to get enough funding that we could select 10 medical schools this year. So the awards have just been made, and our medical schools will begin their programs this academic year. And we are just, really looking forward to seeing how each school takes on this challenge, how they can help each other, and how we can help them.
And will I get to meet these folks at the meeting in June?
If you wanted to, you could meet the people who you won't be able to meet the medical students. We haven't started that part yet. But
I might scare them off.
Well, you wouldn't scare them off. But you'll be able, if you wanted to, we could certainly have you meet the faculty members who are going to be leading these at these 10 medical schools.
Yeah.
And we can talk about that when we see each other at Endo in 2 weeks.
Now, I'm excited. So had I not met you at that dinner, first of all, I wouldn't have now had a new friend and learned a lot. I've learned a lot from you. And second, I would have never known about the Endo Society meeting. So for any of those listeners that, are interested in endocrinology, especially if you're near Boston, I think it's June, the first weekend of June.
Yeah, it's June 1st through June 4th, I think.
June 4th. That's right.
And come on down. We'd love to have you.
Yeah. No, I can't. I'm so looking forward to it. I can't wait. So so as I close, right? So I'm going to go on this living connected theme.
Yes.
Is there someone, Rob, that in your life, right? Because we all have, as we live connected, or as human beings, we have some connections that are, brief moments in our lives, and others that have just been there through our entire development. Is there a connection that you can think of that is particularly meaningful to you, whether it's a mentor or someone personal in your life?
Yeah. Well, I mean, when you talk about personal in your life, you certainly have to talk about your spouse and your children first, because those are the people to whom you're
Bravo. I
most
agree.
connected. And so shout out to Marcy and to the kids, and to parents, of course, as well. And this weekend we'll be celebrating my mom's 85th birthday, so very excited about that. But professionally, we all have people who have touched our lives as mentors in one way or another. And I think if I had to pick one, when my first faculty position, I had a mentor who's since left us. His name was Luis Martin, and he was, I think what his special power was his ability to connect with others. He was the kind of person that you got excited when you saw walking down the hall. And he just had this wonderful sense of humor, ability to relate to anybody, a way to put people's clinical issues and personal issues in perspective. And this wonderful talent of being able to spend just a short amount of time with someone and just come away with insights about that person that were hard for you to believe that he was able to do in such a short time. And I think what Louis taught me more than anything was the importance of that connection. And it's something that I think about a lot. If I mention Louis at home, I always get an eye roll because, how many times is he going to mention Louis, so I would have to say that would be professionally the mentor that I feel the most connected to even though I don't get to see him anymore.
I love that. Awesome. Thank you, Rob. Thanks for being a guest. Thanks for being the first guest. Hopefully, this is not the first and last podcast. We're going to see how this goes. But I really appreciate
it's going to be the last one, Arti. I can't tell you how honored I am to be your first guest, and I wish you the best of luck, and I'm looking forward to seeing you next week.
Thank you. Thank you.